Hello, everyone. My name is Kayla Guerra, and I'm very sorry I could not be present today. But thank goodness for technology, because then I am able to present to you virtually. We will be going over the H1N1 influenza pandemic and going over the timeline, prevalence, data, a lot of the background information about H1N1 influenza pandemic, and also kind of where it's at today and how that has contributed to the public health field currently. First, we will be going over the who, what, when, and where. The H1N1 virus primarily affected children and young adults, and those higher risk were also those with underlying medical conditions. The reason the H1N1 virus spread so quick and so fast is that it was composed of a different strand than the normal seasonal flu strand. Since it was new to the public, there was no antibodies for it and no vaccine available for the H1N1 virus. The H1N1 outbreak occurred in the spring of 2005. The first case, also known as Patient 0, was a 5-year-old boy living in Mexico. He was the first documented case of the new strand of H1N1. Once the virus was selected and prevalent in the United States, it ran rampant through the communities and towns like we hadn't seen in a very long time. It eventually reached many countries and spread throughout the globe, resulting in a pandemic of H1N1. For the hypothesis, the H1N1 strain responsible for the current outbreak possibly circulated among humans for several months before being identified as a new strain of flu. Since symptoms were like the normal seasonal flu, without proper testing, there was no way to know, only based on symptoms, what strand you may have had. This is very important because it also reflects the data that is collected in regards to the H1N1 virus and the gaps that are also present within that data. The types of data that were used was mortality rate, characteristics of the sick, and number of people infected. So approximately 7% of the world's population died during the 2009 H1N1 pandemic. The characteristics of the flu were very similar to the seasonal flu, and the symptoms included fever, cough, sore throat, body aches, headaches, and chills. And approximately 60.8 million cases of H1N1 took place from 2009 to 2010. The data is very alarming, and because of the similarity to the flu, there would need to be testing to determine the strand. Medicine given at the time could only help the symptoms, but not fight off the H1N1 virus alone. I will be saying a lot of words in related to data, which is approximately or estimates, just because there is those gaps within the data, because if an individual was showing symptoms similar to a normal flu and they didn't receive the correct testing, there's no way to document it was an H1N1 related virus, H1 related case, H1N1 related death. And so I do want to make sure there is that transparency there within that data and the information that is presented today. The prevalence system of symptoms, the clinical presentation of the H1N1 symptoms are similar to the seasonal flu. Fever was present in 94% of patients, a cough was present in 92% of patients, and a sore throat was present in 66% of patients. While many other symptoms could be present, the key is understanding that without a testing kit, there is no way to determine the strand of the flu present. This is what made H1N1 so alarming and often made individuals sicker than the common seasonal flu. Next, we'll be looking at the outbreak investigation timeline. This timeline really points out how quick the virus spread, resulting in a quick call to action across agencies, health organizations, and governments globally. So in April 18th of 2009, that first H1N1 infection was reported by CDC. Again, that's referring to the 5-year-old in Mexico, which was the first documented case of H1N1. By April 22nd, Emergency Operations Center activated by CDC. By April 25th, the public health emergency was declared by WHO, which is the World Health Organization. April 26th, the U.S. government declared H1N1 a public health emergency, and by April 28th, the FDA approved CDC testing for H1N1. By May, H1N1 summer activity peaked within the United States. By May 6th, the CDC distributed recommendations and guidelines for H1N1, and by June 11th, WHO declared H1N1 a pandemic worldwide. June 25th, at least 1 million cases of H1N1 occurred in the United States. Again, this is only in the United States. That 1 million does not represent the cases globally. July 22nd, clinical trials for the H1N1 vaccine began, and by September 15th, the FDA approved 4 H1N1 vaccines. And by October 5th, the first dose of the H1N1 vaccine was given within the United States. Of course, with any outbreak or any pandemic, there's going to be difficulties encountered. This represents the difficulties that healthcare workers encountered that actually worked on the front lines of the H1N1 virus. This survey captured how they felt about their institution and how they felt their institution was well equipped and prepared for the overall H1N1 crisis. Healthcare workers felt that their hospital neglected other infection prevention that was not related to the H1N1 virus. 18.2% agreed that there was a shortage of antiviral medication, while 22.9% agreed that their hospital was stockpiling antiviral medication. And overall, only 29.4% of healthcare workers believe their hospital was well prepared for the H1N1 outbreak. That is very concerning, because not even half of the frontline workers felt their hospital was equipped and prepared to handle an H1N1 outbreak. This is important because hospitals are definitely the catch-all as well for surgeries and other infection control. And so if they couldn't handle what their normal capabilities are with an outbreak on top of that, this is something that should be taken into consideration when it comes to funding or policies moving forward within the public health sector, especially related to epidemiology. So prior to the H1N1 virus spreading across the globe, it originated from an animal. Seasonal flu virus does not originate from an animal, but from other humans. That's what makes the H1N1 virus so unique. I do also want to point out that the H1N1 virus is a type of influenza A. It also goes by the name of swine flu because it is a new combination of influenza that infected pigs, birds, and humans. And it also resembles a respiratory infection that pigs can get. The way the pathogen is transmitted is that the H1N1 cells infect your nose, throat, and lungs. It can spread via air droplets when someone contagious coughs, sneezes, breathes, or talks. And it can also stay on items that someone may cough, sneeze on. So it's important to disinfect any items that an individual may have contaminated. The most at-risk and impacted populations were children, young adults, individuals with underlying medical conditions, pregnant women, indigenous populations, which I'm referring to those who live in either isolation by choice or live on reserves. The overall impact of H1N1 is likely, again, underestimated, with no final data to unfortunately show the true impact of the H1N1 virus in 2009. These at-risk populations were targeted as those who could easily contract the virus and would have the hardest time fighting it because of their either weakened or developing immune system. So looking at children and even pregnant women who have fetuses, they're currently developing their immune system. Those who have underlying medical conditions, such as those who have cancer or any chronic disease, are going to have a harder time fighting a virus such as H1N1. Control measures. So to eliminate the spread of the H1N1 outbreak, there were precautions engaged at the hospital level, which are these listed below. And then there were also actions taken at the global level, which I will go over next. So to minimize the source of infection, a hospital meant that they would eliminate elective visits and surgeries, only performing life-saving and urgent surgeries, which also included denying entry into hospitals and clinics to visitors. Engineer controls. So this included installing partitions, which are those glass or plastic clear frames, and using ventilation throughout the hospital. installing hand-free soaps and bathroom items such as, censored dryers and censored toilets to eliminate the touching of these items, and they're commonly shared items as well. Administrative control. So this includes vaccinating healthcare workers, enforcing masks for healthcare workers and staff, and screening staff and patients. The screening typically may include temperature checks. It can include asking symptoms. Have they had a fever within the past 24 to 48 hours? Or asking any of the symptom-related questions. And lastly, personal protective equipment. This is also referred to as PPE within a hospital or a medical setting. This would include wearing the appropriate gloves, masks, gowns, respirators, or eye protection. So again, these are the control measures that were implemented at a hospital level, but I believe truly impacted how things were handled at a global level. Control measures at a global level. To begin, we'll look at capacity building and assessment. This ensures that the minimized spread and risk. The WHO published an influenza guidance. In the guide, there is a 6-step approach that was revised in response to the H1N1 virus because of the strand being transmitted via animal to human. The pandemic alert and risk assessment. So this is adjusting pandemic and alert levels, which were also reevaluated because of the H1N1 virus. WHO, which again is the World Health Organization, hosted an emergency meeting to beam the alert plan across countries and to its citizens. So navigating and reevaluating how this approach would be taken. Response measures. The response measures include a pandemic response, treatment, vaccine, development, and distribution. Because of the H1N1 virus, these control measures were also reevaluated by the WHO. Coordinate vaccine research and development. After H1N1, WHO reached out to pharmaceutical companies to begin mass production of the H1N1 vaccines. This would encourage the worldwide support of influenza A vaccine production because the H1N1 virus is seasonal, meaning that there would need to be mass vaccine production to be able to support a seasonal vaccine, just as the normal flu vaccine you may receive. H1N1 cases. So this graph shows the cumulative estimate of the 2009 H1N1 cases by age group. Over the course of the year, the age group 18 to 64 years had consistently the greatest number of cases for H1N1. Because of the wide range for this age group, it holds the most pregnant women and those with underlying medical conditions, resulting in it being the most impacted age group. Slowing down the H1N1 virus. To slow down the spread of the H1N1 virus, which is also known as the swine flu, there were great successes that helped minimize the outbreak and bring it out of the pandemic. Gene sequencing technology. These labs were able to use molecular testing to pinpoint accuracy when testing for H1N1. It is able to look at the virus's genetic makeup and genome. Testing kits. Clinicians had more accessibility to testing and to rapid test kits. Because of many false negative tests being given, the 2009 pandemic brought about more accurate, rapid influenza test kits. Surveillance. The large amount of testing the H1N1 outbreak helped contribute greatly to research about influenza and provided optimal levels of surveillance. Vaccine effectiveness. Seasonal vaccine data helped contribute to the H1N1 vaccine. It helped monitor the severity of the outbreak and helped agencies respond appropriately. Now looking at H1N1 deaths in 2009. This graph represents the H1N1 related deaths from 2009 to 2010. The curved line displays an increase in the deaths in the peak of the pandemic. It also represents how rapid the virus spread and greatly impacted the globe. And as you can see, the jump from April to October 17th, from April to November 14th, that massive spike is extremely alarming, and that's why it's important that we capture data to have an accurate representation of how a virus can impact the